Well, welcome everyone. We'd like to thank Oculus Surgical for hosting this video chat. We will be discussing enhancing retina and macular surgery through visualization. And our speakers will be Dr. John Kitchens from Kentucky, Dr. Marcelo Sass from Buenos Aires, Argentina, Dr. Leila Vaskovich from Duke University, Dr. Diego Ruiz Casas from Madrid, Spain, Dr. Nina Berrocal from Bascom Palmer, Miami, Dr. Andre Maya from Sao Paulo, Brazil, and myself. Thank you all for being here, and thanks Oculus for hosting this. And we will begin with Dr. John Kitchens. Next slide, please. Dr. John Kitchens will talk about benefits of the disposable high-definition lens in diabetic traction retinal detachments. He is at Retina Associates of Kentucky in Lexington, Kentucky. Thank you, John, for joining us.
Great. Thank you so much for having me, Maria. I'm very grateful for being here. My case is going to be one that I think sometimes we all struggle with, which is essentially this very adherent mid-peripheral vitreous. And I'd be very interested in knowing how you and the others handle something like this. This is a diabetic patient that had vitreomacular traction. It had prior PRP. And so we start out by doing a core vitrectomy, and I notice immediately that it's just very difficult to elevate that posterior hyaloid. So I'm using some max grip forceps under high magnification here to try and elevate that vitreous off of the optic nerve. And normally this is something that once I've gotten it up off the optic nerve, I can see that it's going to separate successfully, and the fluid kind of helps, cause that vitreous to continue to separate. But in this case, as soon as I got the vitreous elevated off the optic nerve, it was just stuck down everywhere. And so I go in and I'm using my cutter and I'm aspirating. And what you can see here is that as I'm peeling this out into the periphery, it just wants to snap back into position and really is incredibly adherent. There's areas of vitreous schisis that makes it very difficult. And one of the things that I absolutely love about not only the NGenuity system, but actually the Oculus HD lens is the really great view that you get in the mid-periphery. And I find that in very difficult diabetic patients, oftentimes it's not the posterior pathology that causes you trouble, but it's that mid-peripheral vitreous that can just be so incredibly adherent. So I'm using ICG and I'm staining in hopes of peeling the ILM and hoping to get this vitreous fully separated. And what I find here is actually that there's vitreous schisis even over the macula, despite having what appeared to be the vitreous up off of the optic nerve. It's yet another sheet of vitreous. But once again, this seems to loosen that vitreous somewhat. This is an area inferiorly at 6 o'clock, and that area was very dangerous because it was quite adherent to this very lasered area of retina. And I was particularly concerned if I created a break in that area that there wouldn't be much for me to be able to laser to. But fortunately, using my cutter and elevating that vitreous up, I'm able to actually have a firm grip on that. And I'm able to actually dissect that free. And then using some of the fluid from the NGenuity system, the 10,000 cut per minute beveled cutter, I'm able to actually segment and get under those areas of plaque. And then once you get that final layer of that vitreous schisis elevated, you're able to actually start to have success 360 degrees. So now you can see I'm able to elevate that vitreous and get it up all the way around the mid-periphery. And then there's actually some room there for the peripheral laser fill-in. And I always do like to go to air in case there's hemorrhage that needs to kind of coalesce into the back of the eye. And just to ensure that we've gotten every little bit of blood out. And it also helps me to identify some of that peripheral vitreous that may still be adherent there. So that was a case just demonstrating the benefits of that mid-peripheral visualization that you're able to get so well with the HD lens combined with the NGenuity system. No chandelier light used on that. It was just a wide angle light pipe cutter and the forceps.
Maria, we can't hear you. Maria, we can't hear you.
Okay, can you hear me now? Can you hear me?
Perfect.
Okay, what I was saying was that this lens really makes it easy for us to see the fovea. Oftentimes, it is very hard to know what's going on, and in these diabetics, vitreoschisis is a very common phenomenon. And oftentimes, not only is the lens useful for that, but sometimes restaining with triamcinolone can be useful. And particularly being able to see really well in the areas of adhesion is useful. So, you know, Leila and Nina have a lot of experience also with intraoperative OCT, which can be useful in these cases too. Do you have any comments, either of you?
Yeah, I'll add that. I'm sure Nina has plenty of comments as well, and welcome hearing from her as well. But I found that OCT actually in these particular cases, when we get schisis, may be helpful to identify that area. I think the stain beautifully identified it as well. But I found like OCT is actually helpful in these particular cases, identifying that area of schisis. And I find that actually when you do use the HD disposable lens, the OCT quality is much improved as well, because we don't have some of the impurities that we have with glass lenses that, you know, with time have been scratched and potentially have a residue that's there. So I think that's another plus of using the lens in kind of OCT cases.
Oh, great.
Yes, I have to say that what I enjoyed of John Kitchen's video, which he did so elegantly, is that when you're elevating hyaloid that is so, it's almost like a trampoline that it wants to pull back. You did that in every area very slowly, because sometimes the inexperienced surgeon will go and elevate one area completely and tearing areas around the laser that are far from the area that you're lifting. And I think John demonstrates that beautifully.
Yes. Okay. Thank you so much, John. Any other comments?
Really nice case.
Okay, we can continue with Dr. Marcelo Sass.
Thank you, Maria. Thank you all. Thank you, Ariel, and all the Oculus team for this opportunity to share with friends and experts. I'm going to show, maybe if we have time, 3 cases of PDR patients and also an epiretinal membrane case. If I can see my video. Here, the PDR patients are maybe one of the most, you can see here a case of the 65-year-old patient with one eye of just an proliferative case, and a huge PDR in the left eye, and also a macular hole. I think this kind of patient, one of the most things with NGenuity and the overlay of all that diffusion technique that we have is visualization. And I think here, this kind of HD disposable wide field lens gives us the visualization to watch not only the posterior pole, that's the equator, and also the periphery, as John presented in the previous case. So if you can do magnification also with NGenuity and with this kind of great lens we have now, you can see how we are drainage this kind of combined retinal detachment with the macular hole, and there was some blood and subretinal fluid, and we can drain it under or across the macular hole. Then with unimanual technique, with this slam beveled, going to 10,000 cuts per minute in 25G, You can do it by manual or unimanual technique, peeling and trying to liberate this kind of traction to try to liberate the membrane, just to get the detachment to get flat and to complete the vitrectomy. I like bimanual technique. Also, I do chandelier in 100% of my cases because I can feel comfortable during the manipulation of the membranes. I have great good videos over there, and I can see I have control in all the vitreous cavity during the vitreous fueron exchange and peeling the membrane. As everybody we have some iatrogenic tears or in this kind of ischemic the PDR patients. We laser all also in PRP. We complete PRP. We can go to the periphery, do some indentation, also in the periphery, and also through the tears. And also then we can put the IOL, finish the time, finish the silicone oil tamponade, and you will see now the pictures in this is the post-op, and you can compare the pre-op with the aggressive PDR and the post-op where the macula was quite clean and the PDR was quite in control. And this is kind of visualization and technique. This is a second case. I'm going to show you another disposable HD and wide field, and also when you can use this kind of pivot lens, and you can see in a wide periphery. This is a monocle 90-year-old patient with AMD, with a vitreous hemorrhage, with a massive submacular hemorrhage combined with vitreous hemorrhage. So we decided to make a 25G vitrectomy. We are taking all the vitreous with the complete visualization. Also in this kind of patient, we use the chandelier lights. And you can see a huge hematoma, a very huge submacular hemorrhage in the left eye, also in the temporal, posterior pole, and inferior quadrants. There was some zones that were thicker, the one that were thinner. And this kind of cases in a monocle 90-year-old patient, you want to get a displacement of this clot and get into the retinal space. So we do this kind of technique. We're doing this kind of cannula in 23, in 25 and 38, on 25 and 41, getting injection of TPA, filter air, and anti-VEGF to get to access to the subretinal space. And you can see how the filter air as a mechanical manner can mobilize the clot to the periphery of the retina. You can see here, this is when the retina was thicker in inferior quadrant. You can do it manually, and you can do it with viscofluid infusion of the constellation, and go to the posterior pole where the retina was thinner. You do an aerofluid exchange, and also the TPA. You can see here the pre-op, the intra-op, and the post-op where the macula was clean. You can see the AMD as the pathophysiology of the massive submacular hemorrhage, the gas bubble, and the displacement to the periphery of this kind of vitreous, massive submacular hemorrhage in this kind of extreme cases, or rare cases we can receive in our office. And when we have time, I'm going to show you another PDR patient. This is a fake PDR patient with the vitreous hemorrhage. The patient have a previous PRP. Instead of that, he has a rebleeding of the case. And you can see here how we combine the disposable HD wide field lens with the chandelier with nice view of the vitreous cavity. You can do that in indentation with the chandelier. I like this kind of maneuver because you can do an efficient and a complete vitrectomy to clean all the vitreous vase, and also if the patient is pseudophakic. And here you can put the pivot. You can go to the posterior pole as the macula lens, what you use in the past with the contact lens, and you can see how can we aspirate with this kind of extrusion, and how can have one nice control and visualization of all the focus of the posterior pole. Also, in this kind of patient, you have to be aware of the membrane, so we stain the posterior pole with BBG, with brilliant blue we have in Argentina, and you can see here how the focus gives us with this kind of magnified posterior pole lens of the brand. You can use, and I like the finest loop to guess the cleavage plan to peel. You can do it shortly, or you can do it longer. It depends on you. just to get the plan of this ILM to get with the revolution handle and the ILM forceps, and you can peel in this kind of cases of diabetic patient to peel, and to get this control of the visualization. As I said before when I began my presentation, visualization is maybe the most useful tool we have now with this kind of techniques and the lens and the 3D surgery to control this kind of, in the example, not only retinal detachment patients, also in PDR patients to make laser, to peel the membrane and to stubble. You can see how we can do the laser on the periphery, the indentation in 100% using chandelier lights. We complete in the posterior pole using the central retinal air fluid exchange. And you can see here the post-op with the OCT and the wide field photography. We can give anti-VEGF injection during the surgery. And you can see here when 2040, the post-op image, the OCT, there's no epiretinal membrane, and the cases was done with good results. Thank you again for your attention.
Thank you so much, Marcelo. These were beautiful cases. I have a question for you. Don't you feel that with these lenses, both the pivot and the HD, it is much better to see under air, which used to be a problem in the past, having good visibility under air?
Exactly. That's a good point, Marie. You can see better under air. You can see, as we know, almost to the periphery. But if I'm operating a pseudophakic, or if I put the IOL in the second time after the vitrectomy, you can have some difficulties during using air. But I think these kind of lenses are very useful during, under air, better than the older lenses that we have in the past. I agree with you. Yes. But I prefer to go to air after the time, because I am quite afraid from the air, because can gain some blurred vision to the posterior capsule through the lens. If the patient was operated by cataract by another colleague, and the air can go to anterior chamber, so I prefer to operate under fluid.
Okay, perfect. Another question for you: when do you choose to use the pivot lenses versus the HD?
It depends on the case. I have it all in my OR, so it depends. If I am doing only a macular case, epiretinal membrane, I prefer to go directly, because I used this in the past with the macular lens, the directed contact one, because I have more magnification and perfect focus during 100% of the surgery. But if you want to have better videos and you want to see, or you are peeling a very large or huge epiretinal membrane, the central retinal lens with the pivot gives you, with NGenuity, a great view during the peeling, and you get better images and great videos. But you can use, it depends what you are and you want.
Well, thank you very much, Marcelo. Those were great cases.
Thank you, appreciate it, Maria.
Yes, our next slide. Yes, and now it is my pleasure to introduce to you Leila Pasovich, who will talk about chronic and large macular hole closure with amniotic membrane. Leila is an associate professor at Duke University in Durham.
Thank you, Maria. Thank you so much. A pleasure to participate. Thank you for having me. I'm going to be presenting a 79-year-old female who you just saw slides of, had actually prior history of repair over the last 4 months, has had a known ILM peel, and we were debating what exactly the approach was. So I actually adopted this technique from Stano Rizzo, where he's using amniotic membrane off-label use for these chronic large holes. And this particular hole was over 800 microns in size, and that alone was question whether it would be closed. And as I mentioned, it was also previously attempted closure for 2 times. So as you could tell initially, this patient already had vitrectomy, was stained with ICG, and really no staining there was noted, and known ILM peeling in the past, one including myself. So I know that there was not much of a ILM to address there. So you see me using a finesse loop here to aggravate some of the edges, the surface edges, to make sure there's not a fine membrane to remove there, not one that I visualized on OCT, but one that's of important to aggravate and just promote some of the healing on the edges there too. So you saw me here bringing in a fresh, actually previously frozen amniotic membrane, and using derm punch to really cut out little tiny pieces. And here it's a 1 millimeter derm punch, which based on the OCT size likely would be adequate size for use. And you'll notice I will take with the basement membrane down intraocularly. And here really the key is in visualization. And you'll notice me that I'm actually using wide field lens and really magnifying in for at times to visualize a little bit more of a macula and fovea and kind of macula and periphery, and then switching back and forth between the contact lens and super view I find very helpful, because not only clarity of it, but it also stabilizes very well over with those 4 legs over the cornea. So I find that I don't have to adjust very much as I'm looking at other portions. And you notice that I stuffed an amniotic membrane into the hole, but also the edges were stuffed underneath the retina itself. And you really want to have some of the overlap to allow for that membrane to stay there. And here on wide field viewing, just it was previously mentioned, with these high definition disposable lenses, we really can reach far peripherally to visualize, and we're just depressing to make sure that there's no tears or anything else identifying the periphery. And I often use this disposable high definition lens, not only with Leica scopes and BIOM, but really routinely with Zeiss. And I mentioned how I really like it for intraop OCT use because of the clarity and allowing really improved OCT imaging as well. So that was the fluid air exchange, and then gas added. This is a post-op 1 month image. Well, you'll notice that the membrane is present there and some of the retina is overlapping there. Here's another case just illustrating, again, placement of amniotic membrane. And in this particular case, we use an OCT to help us judge whether the sizing was appropriate. Sometimes it's undersized, sometimes it's just not, the edges are not overlapping as well. And you'll notice us using the OCT to help us really define that a little bit better. This patient also had DSEC previously, so you'll notice that the clarity of viewing in the back was really limited because of the cornea itself. So OCT in that particular case was even more helpful because it helped us identify the edges. So that was a little bit of a quick summary of some of the cases I've done with amniotic membrane, and I find it helpful for these chronic large holes where prior surgeries were attempted and without success.
Thank you very much, Leila. Those cases were wonderful. So is amniotic membrane your preferred method for these large macular holes?
Yeah, so I've kind of over the time evolved from, using platelet-rich plasma to plug some of these holes to now amniotic membrane. But I think really truly my preferred method currently is a subretinal injection of fluid and kind of stretching out some of the retina and approximating it that way. It also is still limited by the size of the hole itself, but I find that technique where you're detaching the macula and then with finesse loop kind of aggravating the edges and approximating the fovea or closing that hole that way, I found that technique actually to be most helpful, because I feel like we may be plugging the hole with material, but really ideally if you can close or promote closure of these large holes, I feel like they have the better outcome with their own retina and kind of integrity there.
Thank you very much, Leila. Another question for you. When you do the amniotic membrane patch, do you leave air, gas, or fluid?
Yeah, so Standard Visit has described using air. I don't think I've been as courageous because I've had cases where even during fluid air exchange intraoperatively, the membrane dislodges. So you saw me actually doing that step very slowly and not really stepping up full force on the extrusion and vacuum. So for that particular reason, I've always erred towards using gas and even longer acting gas in these some of these cases. Again, didn't want to have that membrane dislodged down the road and have that experience.
Well, thank you very much. Our next slide, please. And now it is my pleasure to introduce Diego Ruiz Casas. He is in Ramón y Cajal Hospital in Madrid, Spain. And he's going to be talking to us about the comparison of macular contact lenses and how white field is enhanced during the Carnavale lens implantation in aphakia. Thank you, Diego, for being here with us.
Thank you, Maria, very much, and thank you all. The first video is a comparison of the macular visualization quality using the BIOM 05 non-contact lens and 4 disposable macular lenses. The contact lenses are the wide field macular lenses from Alcon, Dork, and Oculus, and 1 magnifying lens from Vitrec. The case is a localized subretinal and sub-ILM bleeding from a macroaneurysm, and you can see the excellent view of the BIOM 05 no contact lens. I start peeling the ILM to get a distance reference for the contact lenses, and I can reach, as you can see, and peel the ILM if I could far beyond the arcades with this lens. Now I'm showing you the macular visualization with the best microscope settings for that I found for each disposable lens. The Alcon lens allows ILM peeling in the whole macular area, but it is unstable in deep eyes due to the eyelid speculum contact. The Vitrec lens, unlike the others, is magnifying and gives a sharp image, but a small field of view that forces the surgeon to tilt the eye to get to the arcades. And as you can see, I'm peeling the ILM towards the sub-ILM blood in order to remove it. You can see it there. And the quality of view is quite sharp, but the field of view is small. The Dork lens is similar to the Alcon one, but more stable in deep eyes because it doesn't have feet, although it moves over the cornea in longer eyes. After ILM peeling, I removed the proretinal blood, and in this case, I left the subretinal hemorrhage to reabsorb by itself because it didn't involve the macular area, the foveal area. And injecting RTPA in this case would be more harmful, I think. And finally, this is the Hacen Tornave Oculus lens. It has an excellent stability in deep and long eyes, thanks to the flexible feet. But the best thing is the excellent field of view that it provides without losing resolution. In fact, it is my preferred contact macular lens. And now I'm going to show you the visualization with each lens with the same zoom and the best focus of the microscope. You will see now the 4 lenses, and you can observe the massive difference in the field of view between the wide field lenses and the magnifying one. And among the 3 wide field lenses, the Oculus one has the best field of view with a very sharp image in the lower right corner, as you can see. But observe this. What about this? The non-contact BIOM 05 lens gives you excellent macular and peripheral visualization under BSS and also under air, and you can use it for all the vitrectomy tasks, macular and peripheral work. It is actually 2 lenses in one, and it is my preferred lens for macular work, except in myopes, in which I use the ocular Hacen Tornave lens to improve the resolution. And this is the next video, and I'm showing you my preferred technique for IOL implantation without capsular support. And it is the scleral fixated Soleco Carlevale IOL. And this is my surgical techniques. First, I perform nasal and temporal conjunctival dissection and scleral diathermy. And then you can perform either 2 scleral flaps or scleral pockets. The scleral flaps avoid any risk of the IOL external plaque extrusion, but they take a longer time. And scleral pockets are faster, but with them there is a little risk of plaque extrusion, especially in patients with very thin sclera or conjunctiva, myopes, or patients with collagen diseases. After the scleral work, I deal with the vitreous pathology and remove the intraocular luxated IOL with the help of the BIOM non-contact viewing system, which is excellent for working both in the vitreous cavity and the anterior chamber, even with open corneal incisions. And these ones are small, even with the artisan incisions, it is stable. As you can see on the left, I use the same BIOM 05 lens to perform macular and peripheral work, and on the right, a single piece IOL lifting and removal from the anterior chamber. And now I'm going to implant the Carlevale lens at ciliary sulcus. I perform 2 sclerotomies at 1.5 or 2 millimeters from the posterior surgical limbus, and very important, parallel to the iris plane to reach the sulcus. This is the Carle Valley lens you're going to see now. It is an acrylic hydrophilic IOL with 2 scleral plugs and 4 internal optics to fit at the sulcus place. And it is also angulated 10 degrees to avoid posteriorly, to avoid iris rubbing. I inject the lens through a 2.2 millimeters incision. I grasp the first plug with 25G serrated forceps. You are going to see it there. Usually the plug is folded backwards, so you have to tilt a little bit your injector to grasp it easily. And then I inject the IOL in the anterior chamber, holding the first plug. And finally, I take out the first scleral plug, and I use a handshake maneuver to take out the second one. The tips of the scleral plugs are then buried into the scleral tunnels with pockets technique, as you can see now here. I use the same 25G serrated forceps to bury them into the scleral pockets, and it avoids extrusion in most of the cases. And the other technique is using scleral flaps. If you use scleral flaps, I do the same. I do the same sclerotomies at the same distance. But in this case, the optics are going to be, and the scleral plugs, I'm sorry, are going to be buried under the scleral flaps. As you can see there, the best of the lens is that it is extremely stable. It is super easy to inject, and it doesn't produce any damage to the eye. It's extremely harmless for the eye, and with very little risk of cystoid macular edema. After implanting the external plugs, I recommend suturing the scleral flaps and the incision to create the pockets to avoid any risk of leakage or plug extrusion, as you can see there. You can leave it and suture, but it is riskier. And to engage perfectly the inner optics at sulcus, I push the IOL anteriorly with the endolight, and that's it. It is extremely stable this way. It has excellent refractive results and very few complications compared to other IOL implants for a 5K, and this is my preferred technique. In fact, I was using other techniques for IOL implantation. I was using not Yamame because I don't like it, but I was using Scariot and agar-wall techniques to implant the 3 pieces IOL, and nothing compares to this. And I was also using the artisan lens, and nothing compares to this. This one is extremely easy, extremely stable, and the most important thing, the rate of cystoid macular edema after implantation is almost 0. So I like this lens very much, and it also allows you to indent with your BIOM and to perform the surgery perfectly. And I was showing this video as well because we have now an epidemic of IOL luxation into the vitreous cavity, and we have to find the best way to deal with this pathology. And for this pathology, using the non-contact BIOM systems is absolutely necessary, because you can work in the both chambers, and you can leave your incisions open prior to taking out the lens, and it makes surgery much easier compared to contact systems. No way. And that's it, Maria.
Thank you so much, Diego. Those were wonderful cases. I have a question. How long have you been using this case for? These lenses for?
This lens. I've been using the lens for the last 2 years, but it was recently commercialized in Spain, distributed, I mean. Initially, I had to ask for the Italian company for the lens, and I was using that since 2 years ago, yes.
And what company makes the lens?
The company is a very small company from Italy. The name is Soleco. They make also contact lenses and also intraocular lenses for the BAG implantation. But they have this product that for me it is excellent, and you can ask the company for it. And if you try one of these, I'm sure that you will make this your preferred technique for a phakia treatment. That's for sure.
Yes. Thank you, Diego. That looked wonderful. Thank you so much. Our next slide, please. And now it is my pleasure to introduce to you my sister, Nina Baracol. She's a professor of ophthalmology at Bascom Palmer Eye Institute in Miami, Florida. And she's going to talk to us about visualization during gene therapy in pediatric retina. Thank you, Nina, for being here with us.
Thank you, Maria. It's great being here. And thank you, Oculus, for putting this together. So here I am showing you the first case. It's done in NGenuity with the 3D system. And you can see that the view is so nice that the elevation of the hyaloid is able to be done nicely without staining. Just with the vitrector, I can see the elevation. I can see how it goes over the macula. Remember that these cases are LCA cases, Leber's amaurosis. So the retina is thin. There's a lot of atrophy of the RPE. So I did stain it ultimately just to be sure that I removed the entire hyaloid. Since these are kids, I want to be sure that my hyaloid elevation is complete. And I like to do the OCT at the same time just to see, you know, where I am, what I'm doing. Sometimes a bit distracting to the surgeon, but you can turn it off and still record it. And in order to do the subretinal injection, I like to bevel the tip of the subretinal cannula. I try to do it bluntly, but it doesn't work. And I like the AbbVie macular window lens. I think with that, I get the best view to know exactly where I am in that subretinal space. And you can see here, we're injecting 0.3 mL in the subretinal space. You know, you don't want to inject a bleb that's too high because it becomes too thin and you can induce a macular hole in these children. And it would be great if it would expand and it become wider rather than higher. So sometimes you have to do more than one bleb. And the OCT is nice because you can confirm the elevation of your bleb and the completion of the bleb. And always at the end, go to air. You see in there that I had two blebs. The next case, here I'm staining. And what I like to do is use many times it's very hard to remove it from the nerve. So I like the flex loop. And I have found that in these cases of LCA, it's much nicer to start your hyaloid dissection at the macula. And you can see that with the flex loop, I can start that, I can shorten the flex loop, use it as the pick, then go under the hyaloid and start the elevation of the macula. And that for me has worked really well in these cases where it's almost impossible to elevate the hyaloid starting at the optic nerve. And, you know, and just slowly elevate it. And then do your subretinal bleb again. I like the AbbVie macular window lens. I'm sure the HD lens would be great to do because you just use one lens to do the macular work and the peripheral work, which is nice. And here you see another bleb. I'm doing this connected to the machine. The clinical trials were originally doing it manually with an assistant, but that's very hard because you have a delay by the time you want somebody to inject and the time you're injecting. So it's much nicer to do it with the machine. And here you see that I did one bleb superiorly, a second bleb inferiorly, and I did a third bleb. You know, you can do as many blebs as you want as long as you're injecting the right amount of medication. And in this one, we also, I believe we went nasally because we think that also injecting the nasal quadrants is going to increase the visual field in these kids. And we've noticed that we have, you know, the ERD, we have some wattage that we have seen after the injection of the bleb of the medication. And here you can see the OCT just confirming the area of the injection. So, you know, and in these cases, I think OCT is great just to, you know, it lets you know how high is your bleb, you know, did you take the macula, is the fovea off or the fovea is not off? So I think that's really nice to confirm. But I wanted to leave you with the last case, and this is, you know, I do a lot of children, I do a lot of ROP, and this is a baby BIOM lens that I have to adapt to the re-site by taping it to the re-site, and I had to bend it so that I have the right angle, and you can start the movie. So, you know, in baby size, it's really, it would be ideal to have a lens that I could fit all my instrumentation. Now I have short 27 from Dork gauge instrumentation and the 25 short from Alcon, and here you have a 4B detachment in an ROP baby. This is, I think at the time this was a 2-month-old baby. And here I am, I have the OCT. You can see the elevation of the retina with the dragging and the laser in the periphery. So ideally, I would have a lens that I can fit all my instruments, but the lenses that we have right now, and I've talked to the Oculus people and to everybody who's been in my OR, they're too wide. So you do that surgery more straight in. So it's very hard to fit those lenses with your instrumentation. So hopefully in the future, we'll also have lenses designed specifically for baby size. Thank you.
Thank you, Nina. I think probably Oculus will be able to make you a small lens. I think they have some lenses that actually were smaller. I remember in the past, we had some glass lenses that were smaller. So I think it may be possible for them either to get you one of those glass lenses or maybe, reconfigure an HD lens with a smaller diameter. I think that would be really, really useful.
Can I make a comment, Maria? Can I make a comment on this? You can hear me? Can you hear me?
Yes. Yes.
Yeah, it is about this. I know that the Oculus has a reduced lens to work with children, but since they released the black one, the 05 lens, I think it is this one, as you can see here, you see? It is like the reduced one from the golden one. And the advantage is that the size of the lens is quite small, and if you focus the macula, the focus is quite up. So I use it in myopes. I don't do myself children, but in myopes, when you have to go quite perpendicular, quite vertical to reach the macular area, you don't have any problem with this lens compared to others. So I think that it might be useful even in children, this one. Believe me, and the quality of view is excellent. It is my preferred lens now.
Yes, I believe I've tried that, but it's still not small enough to be able to fit all those things. But, I'm sure we'll get there at some point.
So Nina, I know I recently have been working with the team, with Oculus team, to actually design exactly pediatric lens, and they're using the HD disposable lens, which I think disposable lenses in general are a way to go, especially during these COVID times. I think we all are going to be very cognizant of kind of making sure that there's no cross-contamination and such. And we all know while we're operating on our patients, there's often fogging of the lens, and some of it is related to patients breathing onto that area. So I think disposable lenses are the way to go in the future for sure. But one of the solutions that Oculus is working for pediatric patient population is they're kind of shaving the edges of the lens. And that's allowing for a smaller diopter, but it's not really obscuring visualization. It's just as far in the periphery. So I'm sure they'll be intrigued for you to try that as well and help develop.
Yeah, I've seen that lens, Leila, and I think it's exciting because it's something out of the box. So it's just like anything else. We just have to try it, and the idea that edge is going to be cut because it's not round as we're used to. I'm sure we all as surgeons can get used to that if it will do what we want to do.
Yeah, no, exactly. And I love the fact you show that pediatric BIOM taped onto Recite. I think it's a great way to incite, what some of the struggles we go through as we operate in pediatric patients and what adaptations we as surgeons have to come up. So continue showing that so we inspire others to work on things.
Yes.
Thank you, Nina and Leila, for those comments. And now our next slide. And our next speaker, it is Dr. André Maia from Paulista School of Medicine in São Paulo, Brazil. And he's going to talk about cases where the BIOM made it possible. Thank you for being with us, and thank you, Oculus, for having André with us.
Thank you, Maria. It's a pleasure to be with you guys. And, we are more than friends. We are really close. So it's very nice to be with people that we love. So this patient had previous surgery in a different location, different service. He had probably a trauma eye on this eye. So we started doing the phaco emulsification And we like to do the pre-shop because I think it's just easier, especially in patients with mild cataract. So as you see here, the retina was completely detached, and there was a subretinal hemorrhage, very thick. And I like to point it out that I'm doing surgery bimanually, where I'm using forceps and the vitrectomy probe at the same time with the chandelier. And if I'm using the contact lenses, that would be much harder to do. So I think a non-contact lens is a must-go in cases like this. So I'm doing the peeling of all the tissues that is on the retina. So and sometimes I use vision blue to help me to visualize better the membranes. I'm trying to peel the ILM and some of membranes that was sitting on the retina. And I use the PFC to flatten the retina to help me to understand where the retina needs to be cut. And sometimes we can just cut the retina, but at this particular time, I realized that there was a choroid still, so I tried to drain out from outside, and actually a little bit of blood came out. As you see, it's a dark blood, but that was enough. So I decided to put the vitrectomy probe in right there behind the choroid and remove a little bit of the hemorrhage that was sitting behind the choroid. So you cannot see my hands, but it actually, the vitrectomy probe is in between the sclera and the choroid. So I was able to remove the biggest part of the subchoroidal hemorrhage, but there's still a little hemorrhage there. So I decided to leave the subchoroidal hemorrhage, and I proceeded with the PVR removal under subretinal PVR. As you see, there's still something there. So I think they're important to you remove the most you can in a case like this. And once it's done, yeah, I did put a silicone oil. I did the air fluid exchange, and I left it with a silicone oil. See, there is a still choroidal hemorrhage, but the retina did look okay. And I decided to do the laser on a second time because I think the laser could cause even more PVR. So I just closed the eye, and I knew that I had to reoperate this patient weeks later. So that's the second surgery. As you see here, I just start removing the silicone oil. There was a bubble of silicone oil in the anterior chamber, so I removed that. So see, the retina was detached nasally, but the macula didn't look that bad. So I used again the vision blue because I wasn't completely sure. I removed everything. So actually there was still a lot of membranes and PVR. So I worked a little bit more to remove that at the periphery. I put back the PFC, and now there was no subchoroidal hemorrhage. So I decided to increase the retinotomy. And now I did that 360 degrees in order to reduce the risk of having recurrent retinal detachment. And the second surgery with no subchoroidal hemorrhage, so I did a laser 360 degrees and put the silicone oil with the sutures. I always like to suture. As you see, this is a difficult case, but in patients with pseudophakic patients, when you have a good visualization, like a chandelier and good lens, like the BIOM, I think that makes our life much easier. I think in cases like this, you cannot do it with the contact lens. The second case I'd like to present is a patient that had a subretinal hemorrhage. Actually, it was a big hemorrhage. This is actually the second surgery, because the first surgery we did the TPA, but there was still hemorrhage underneath the retina, and the patient wasn't happy. So I decided to do RPE transplantation, a little bit based on what's being doing in literature. So the first thing is to remove the ILM. You have to do that, otherwise you may have macula hole, and that's a bad thing. So I removed all the membranes that were sitting on the retina, and I start with the 360 degrees, completely full vitrectomy. And at the temporal side, the vitrectomy probe reached really close to the retina, and I did cause a retinal tear in order to detach the retina temporarily. So at that point, I think it's very important to have both hands working together while you're depressing the eye with one hand, you're doing the vitrectomy with the other hand. And now also with two hands, as you see, I'm lifting the retina very gently with a finesse instrument. And with the forceps, I grasp the subretinal RPE complex. As you see, here's a very thick membrane. And once that's done, you have to increase the intraocular pressure. That's why you have to have always valve trocars to reduce the risk of having hemorrhage, which is a very bad thing. So once that's done, I put the PFC, and I did a superior endocautery, followed by laser to reduce the risk of having a hemorrhage. With the special scissors, I did a 360-degree cut it, the RP, and gently with two forceps. Once again, you have to have a good visualization system. With two forceps, I gently push the RPE complex underneath the retina. There was a fold, as you see there. So I did little holes on RPE to increase the vascularization, and I gently put this segment of RPE underneath the retina, and gently I use the PFC to flatten the retina back. As you see, there is a whitish around the macula where I removed the ILM. And once that's done, I aspirate the PFC and I did the laser 360 degrees. So that's, I would say, a difficult case. I know it's very controversial about the indication, but the only thing I'd like to point it out is how much easier, not easy, but much easier is when you have two hands in a patient with a non-contact lens like the BIOM. So that's the end of the surgery.
Thank you so much, Andre. Those were amazing cases. And I think you make some important points. One, that we don't need to do everything in one procedure, especially if we're using silicone oil. It is always possible to do laser later, and it does make sense in this case that had the choroidal. Also, you showed a really nice technique of moving the RPE flap under the perfluorocarbon liquid and then injecting more perfluorocarbon liquid as you aspirate and you squeegee it out towards the periphery. I think some people are afraid of using perfluorocarbon liquid under the retina for fear of having bubbles. What would be your tricks to avoid having subretinal PFO in these cases?
Well, I think the most important thing is you have to have a valve of trocars, because if you don't have that, you may have small bubbles, and the small bubbles are the dangerous. Once the PFC is in one block, the risk of having a subretinal PFC is much smaller. That's, I think, the most important thing. The second thing is, every time, if you don't have a valve, every time you remove the instruments from the eye, you really have to pay attention, because the BFS coming from the bottle hits the PFC and causes small bubbles. I think that's the two main, I would say, advices. I would say it is important to pay attention if you're using PFC in the eye to reduce the risk of having PFC under retina.
Thank you so much, Andrea. Our next slide, please. And now I'm going to be talking to you about the advantages of the BIOM combined with the 3D viewing system in complicated retinal detachments with the HD lens. So really, the main thing is to see as best as possible in these cases. Next slide. And in essence, what do we get with 3D heads up? What are the advantages? You get improved visualization, improved depth of field, is ergonomic. The entire OR can see everything and you can point. It's great for teaching. Next slide. Next slide, please. But the advantages of the BIOM lenses and the BIOM system, which is what I've always used, combined with the HD lenses in this, it gives us high magnification, which in many cases, we don't need to use a macular contact lens. It gives us over 130 degrees of view and that enhanced depth of field, and we can view really well under air. Disposable lenses are ideal because we get clear view always, reduced turnaround, and in this era of COVID, it does make sense to use disposables. Next, please. Next slide. And when we combine the two things, actually we get a wider field of view. We get increased depth of field of over 2.7 times, and under air we can see really well. And these lenses you can use, with your size resight microscope also. Next, please. So I'm just going to show you a few cases so that you can see where I think these lenses really make sense. This is a case, a diabetic that had silicone oil. It was referred to me to remove the oil and remove some membranes. And what I'm seeing here, which I see often when silicone oil is used, is that there's a lot of silicone proliferation, and membranes tend to form between the silicone oil and the retina. This happens more in diabetics because they tend to bleed and they tend to have hemorrhages. But here you can see how well we can see the macula without having to use a macula lens. I'm peeling this with the vitrector, which is my preferred thing. But the really nice thing is that we can really see the periphery. And many of these cases give you this surprise, which is that there was a peripheral retinal detachment. The retina was pulled over towards the periphery. In this case, something that I wasn't able to visualize before I started the surgery. And here, I'm sterilely pressing to try and remove all of those adhesions. I think this is really important. In the past, before we used valves and trocars, it was very common to have ingrowth through the sclerotomies, and it can still happen. So it's really important to always examine really well the periphery. And I think the BIOM system is really useful in allowing us to see that. Next, please. And this is another movie. I really like doing buccal chandeliers. I think buckles are really useful. This is a fake patient who presented the day right before Christmas with this detachment. It only had one break. So I am using the BIOM system and a chandelier to illuminate the periphery. It only had one break, but and one little one next to it. But it's really, really important to see well. And oftentimes we don't really like buckles because it's hard to see with the loops and with the indirects. So this really makes this technique so much nicer and easier. And here I'm just using a radial sponge to cause indentation in that big horseshoe tear. I really like sponges. Sponges indent a lot more, and they're very useful for large horseshoe tears like here. Draining under the microscope is a lot better. And here you can see inside, many buckles fail because we're not able to see the periphery really well. And I think the BIOM with the chandelier is really the way to go in these cases. And I think, we're going to start doing more buckles, which is a really good procedure. You don't need any cooperation. The patient sees right away the next day. They can go about their business. They can work. And really the trick, if you're going to use sponges, is really that you need to close tenons really well so that you don't get any extrusion. And here I'm closing tenons. And this case did really well. She was able to enjoy Christmas. This is how it looked the next day I put a little bit of air, and this is right after. Next movie, please. And I think this is a trauma case. The patient the lens was ruptured, had almost a 360 giant tear. It had been repaired with oil, but it reproliferated and PVR occurred and the whole retina rolled up. But what we see here is that there's multiple membranes under the retina, and we can see how well we can really see all this area. And what is nice with the combination with the 3D system is the depth of field. So we are in focus all the way down in the RPE, as well as in the more anterior parts of the retina. And there were some adhesions here that is also common in trauma cases. And as we go under the retina, we can see that there's not only membranes, but there's pieces of lens. Little lens remnants in these cases of trauma are very common, and they cause significant inflammation in PVR. There was also some hemorrhage, which I'm aspirating there, but you can see how everything is in focus. The flap of the retina anteriorly and all the way down. Here I'm injecting perfluorocarbon liquid to flatten everything. Like Andrea mentioned, I think having valved cannulas really makes this very important. I'm using the flex loop to flatten the edges, and then I'm lasering everything under the perfluorocarbon liquid. And these cases really benefit from doing a direct oil perfluorocarbon liquid exchange. And in these cases that are aphakic, I usually do an inferior PI, and I do it fairly large so that I don't get oil in the anterior chamber. And the direct exchange prevents fluid from getting under the retina and getting folds. And it is a nice controlled way of doing this. And you can see how with this lens and with the BIOM, we really have a really nice view of the periphery and of the posterior pole at the same time. And this is the picture sometime after. So next slide, please. So in conclusion, I think the combination of the BIOM with 3D viewing is really the future. I think it gives you optimal wide-angle visualization, increased depth of field, and a really clear view under air, which is really priceless in many of these cases. So next slide. And as such, I really want to thank all of the speakers, next slide, for joining us, and in particular Oculus for their for sponsoring this session, and also for providing us with such useful adjuncts to our surgeries. Thank you, and thank you all for being here.
Thank you all.
Thank you. Thank you.
Congratulations to everybody.
Okay, thank you.